All right, good afternoon, everybody. My name is Dr. Howard Shaps. I am the Medical Director for Healthcare Excel, and today we're going to be talking about catheter-associated UTIs or CAUTIs, and hopefully we'll make our hospitals a little bit safer. So to start with, we're going to give some basic definitions of what a CAUTI actually is, and by definition, a CAUTI is found in patients who develop a urinary tract infection with an indwelling catheter in place at any time after placement or within 48 hours of catheter removal. And the Centers for Disease Control and Prevention, or the CDC, classifies CAUTIs into two groups. You can have asymptomatic bacteriuria or a symptomatic urinary tract infection. We'll go over some basic facts about CAUTIs. 16 to 25% of hospitalized patients have an indwelling catheter placed. And UTIs account for 40% of healthcare-acquired infections. And of these, 80% are caused by CAUTIs. So obviously CAUTIs cause significant morbidity in those patients who are hospitalized. In the ICU, the incidence of CAUTI is 3.1 to 7.4 per 1,000 urinary catheter days. And the economic burden can be quite high, anywhere between $1,200 to $2,700 per episode. And each year, more than 13,000 deaths are associated with UTIs. Here are some basic complications of CAUTIs. They can cause gram-negative bacteremia, epididymitis, endocarditis, osteomyelitis, septic arthritis, to name a few. So as we can see, CAUTI complications can become very, very harmful. Here's a picture of a standard indwelling catheter. And we're going to talk a little bit about the pathophysiology of biofilms, and I'm not going to bore you too much, but it was quite interesting to see how these CAUTIs develop and why people get infected. A biofilm is a conditioning film, or it's a film made up of proteins, electrolytes, and other components that everyone has in their urine, and these all get deposited on the surface of a catheter. And from here, the bacterium can attach to this film, as well as fungi can attach to this film, and it begins secreting sugars or polysaccharides that form the architecture or the structure of this biofilm. And these biofilms that are generated actually become a survival mechanism for the bacteria or yeast, and they offer protection from the body's defenses as well as the antimicrobial agents that are used to treat these infections. And these biofilms can contain multiple species. They're tenacious, they're resistant to antimicrobial agents, and they explain why those patients are at high risk for getting these catheter-associated UTIs. What happens is, in the end, the organisms will detach from the biofilm, become a free-floating organism, and cause infection in the urine and can lead to complications, as we discussed earlier. Here is an electron microscopic view of a biofilm. So, as we can see, this biofilm is pretty important in the pathophysiology and the occurrence of urinary tract infections that occur in those with catheters. So how does the patient become colonized? Well, everyone's got bacteria as well as fungi in their skin, and that can enter the urinary tract. Healthcare providers' hands can be a source of colonization, as well as there can be some ascending. The organisms can ascend from a drainage bag or the catheter bag junction. This often occurs with manipulation of the bag or the collecting system. You'll often see people will raise the bag above the bladder level, and therefore the urine can backflow, and the bacterium or the fungi can get into the bladder. So risk factors are pretty important when we talk about CAUTIs, and most importantly is the duration of catheter use. We know that for each day that the catheter stays in place, the chances or the incidence of having infection increase dramatically, somewhere between 5 and 10%. And those with long-term catheters are almost assured of developing some sort of infection or the CAUTI. Urinary stasis and overdistension of the bladder is also a risk factor for UTIs. Some other risk factors, females are more at risk. Those that are old, those that are extremely young, neonates. If a close drainage system is not maintained, it could be a risk factor for developing a CAUTI. And then immunocompromised patients are also at risk for getting these infections and complications from these infections. So first and foremost, hand washing is extremely important to prevent the infection from occurring. And here's a little bit of a stop sign to show you to wash your hands. Very, very important. Another preventive measure is to reduce unnecessary catheter uses. It's estimated that up to 50% of urinary catheters are unnecessarily placed. And when we decrease the use, in general, we can limit the use or minimize the duration. And those are two key ways to reduce the actual use of the catheter. And one additional way is for hospital staff to use a portable bladder scan. And by using this, residual volume could be assessed and it may negate the need for placing a urinary catheter. People patients are thought to have urinary retention. And most important, or very important as well, is reducing emergency department placement. And we're going to see in a moment how vital it is to decrease the emergency department use of urinary catheters. And here's just a couple pictures to make you laugh. Obviously, this gentleman doesn't want the catheter, and for many good reasons. Perhaps he knows that he'll develop a CAUTI should he have one. And sometimes you'll see that nurses don't always say things that they're supposed to be saying. So from an emergency department utilization standpoint, the urinary catheter is placed very, very often in the emergency department. So here's some statistics. 64% of all patients catheterized while in the hospital had it performed in the emergency department. And in another study, there was a 12% catheterization rate for over 4,000 patients that were admitted through the emergency department. So more than 1 in 10 in the ED get catheterized. And of this, only 13% of those that receive the catheters have the indication documented in medical records, and it's quite often the catheter is placed for unknown reasons. So here are some guidelines as to when a urinary catheter should be placed in the emergency department. If there's suspected urinary flow obstruction, neurogenic bladder, urologic procedure, those patients that have vasoactive medications that are being given to them may need urine output monitoring. Those that are going to emergent surgery, certain patients with decubitus ulcers may need the catheter to prevent the urine from getting into the wounds. Hospice or palliative care is an indication. Those patients that have a hip fracture and can't get up to go to the bathroom may need one, as well as those patients who have severe hypoxia, unconsciousness is an indication, as well as if an emergent pelvic ultrasound is needed, if you need to drain the bladder, that may be an indication for the urinary catheter. And here are some reasons not to place a catheter. Convenience. Often, patients will even ask to have the catheter placed, and sometimes the nurses will ask to have the catheter placed. So convenience is not a reason to put a urinary catheter into a patient, especially in the emergency department. Age is not a determinant. If the patient is incontinent without any of the above indications, it's not necessarily a reason to put the catheter in. When you're diuresing a patient, a catheter does not need to be put in as well. If you don't have to determine urinary output, catheter should not be placed. And then when patients are being transferred from different units in the hospital, it's not a wise idea to put a catheter in as well. So here are some ED interventions that can be implemented to help decrease the catheter use while the patients are, decrease catheter use and decrease catheter-associated infections. Education is important, extremely vital, and by giving the staff baseline rates of appropriate use, you could help them determine whether or not in the future a catheter needs to be placed. So not only do physicians need to be taught, the nurses need to be taught, and in addition, the staff in the emergency department, everyone has contact with patients. By giving the staff members specific criteria for use, as well as teaching them about problems of overuse, hopefully these infections can be prevented. And quite commonly, people are using urinary catheter indication sheets these days. Interdisciplinary team typically will form this, will create criteria and create a sheet. There's a checklist. And if the reason for putting the catheter in is not on the checklist, it may not be a good idea to put the catheter in. And this indication sheet can be attached to all catheter kits. And as well, in the department, emergency department specifically, frequent reminders about appropriate use could be taught to the staff or given to the staff just to keep it in their ear that perhaps the catheter doesn't always need to be placed. And here is just one author, one study that was done, and it gives a typical indication sheet for putting a catheter in. And this gets attached to the catheter kit, and it gives you the name of the patient, sticker can be put on there, as well as the diagnoses. And then these are the criteria that they used to place the catheter. If the criteria in that list was not present, it asks you to write the reason why you're putting the catheter in the patient. And then it asks, after you're done, asks you about, after reading the criteria, does a catheter really need to be placed? So when this is put on the catheter kit, it may enable the patient to not have a catheter placed. It may prevent an infection down the line. And there are some positive consequences of establishing ED guidelines. There's one study done that had the guidelines presented to physicians, and they gave them a pocket card to list the appropriate indications for the catheterization. And there was one physician champion that promoted the adherence to these guidelines. And when they did this, they reduced urinary catheterization utilization from almost 15% to about 10.5% or so, which was significant. And then 40% fewer catheters were placed post-intervention as well. So as you can see, education is key, and it will decrease the use of catheters in the emergency department. From an organizational perspective, each facility needs to have written guidelines on the use, insertion, and maintenance of urinary catheters. The indications for its use should be documented. People need to be qualified and trained to place a catheter. And then systems need to be in place for documentation of proper insertion as well as removal of catheters at specific times needs to be put in place throughout an organization. Checklists and algorithms are very important. And with this, the use of catheters can be minimized significantly. So we're going to talk in a moment about inserting the urinary catheter. Here's a little blurb, hopefully to make you laugh a little bit. So insertion and management techniques. As we all know, the catheter needs to be inserted aseptically. It's wise to secure the catheter to the patient's leg, which will prevent movement of the catheter and any kind of traction forces. And this will decrease the rate of urinary tract infections by up to 45%. At all times, a closed drainage system should be used, and urine flow should be unobstructed. The bag needs to be placed below the level of the patient's bladder. And it's good to empty the collection bag regularly and prevent the spigot from becoming contaminated. And all this will hopefully decrease the amount of urinary tract infections that people see in the hospital. And here's just an illustration as to how the catheter can be secured to the patient's leg. Another key to decreasing the amount of CAUTIs within the hospital is to remove the catheters as quickly as possible. And electronic medical records can serve to remind physicians, nurses, and all clinicians that the catheter, may be time to come out. And often we'll see nurse-driven catheter removal protocols. So the patients will be evaluated daily by the nurse, and the nurse will then prompt the physician to hopefully discontinue the use of the urinary catheter. And this, again, will decrease the amount of CAUTIs that are found in the hospital. And here's a graphic that we alluded to a little earlier that shows the risk of infection with the number of days that the patient is catheterized. And although it's not perfect, according to this study, it goes up about 5% a day, and the general rule is somewhere in that range. So the faster the catheter comes out, the less chance the patient has of getting this type of infection. So here's a case study that was done at Beth Israel Medical Center in New York City. And they've developed a way to decrease the number of CAUTIs found in the hospital. They formed an interdisciplinary team, which was composed of physicians, nurses, nurse assistants, and even transporters. And quarterly, the Board of Trustees, as well as the administration, was given feedback rates as to the number of CAUTIs that occur throughout the hospital. And they set goals. They wanted to avoid unnecessary catheters, and they wanted to care for the catheters per guidelines that were out there. On rounds, the physicians were reminded about the correct use of catheters, and they provided educational encompassing training for their staff. And this was also put into place in the computer physician order entry system as well, prompting them to hopefully remove the catheter or giving guidelines as to why the catheter should be placed. And here's what happened after they implemented their system. The CAUTI rates decreased tremendously. In a lot of the units, they saw a rate of 0. And after this, 66% of patient care areas were able to maintain a 0 CAUTI rate beyond 6 months. Catheter duration decreased by 3 days, and the utilization rate decreased from the 64th percentile to 50th percentile with comparison hospitals. They saw a reduction in multi-drug resistant E. coli and Klebsiella from 1.3 to 0.8 per 1,000 discharges, and they estimate they saved about $320,000 a year since 2009. So they did a very nice job decreasing the CAUTI rates and saving a good amount of money as well. One of the keys to preventing CAUTIs is adequate nursing staff as well. It's been shown that a higher nursing staffing rates is associated with 30% reduction in the risk of healthcare-associated infections in general, and 27% of all healthcare-associated infections could be eliminated if nurse-to-patient ratios were maintained at adequate levels. And then practices used to reduce CAUTIs, consume nursing time, and the better staff you have, the better staff you have, higher quality staff you have, and the more staff you have, it looks like it will decrease the amount of CAUTIs as well as hospital-acquired infections in general. And when patients do develop a urinary tract infection while in the hospital, documentation is very key. So even though the patient has a urinary catheter, has a urinary tract infection, it doesn't necessarily mean they have a catheter-associated infection. So it should be stressed to the physician when they document that if they're not 100% sure that CAUTI exists, it should be documented. The hospital's infection preventionist and infection control team should be called in to see if a CAUTI actually exists. And here are some recommendations, or here are some ideas that are not recommended. Silver-coated or antibacterial catheters are not necessarily recommended. Routine screening for asymptomatic bacteriuria is not recommended. Catheters shouldn't be irrigated. Prophylactic antibiotics are not indicated. There's no indication to change catheters routinely. And cleaning the meatus with antiseptics doesn't have to be done all the time. Routine maintenance is recommended, but peritoneal hygiene is very important. So some end notes for everybody out there. Report UTIs that are catheter associated. So these are patients that had an indwelling catheter placed at the time or within 48 hours before the onset of the event. And there's no minimum period of time that the catheter must be in place in order for the UTI to be considered catheter associated. And the transfer rule is if a CAUTI develops within 48 hours of transfer from one inpatient location to another in the same facility or a new facility, the infection is attributed to the transferring location. And here's some helpful information if people need further information about CAUTIs, preventing CAUTIs. The Infectious Disease Society of America, the Association for Professionals in Infection Control and Epidemiology, and the Society for Healthcare Epidemiology of America are all vital resources we can all use to help decrease these infections. And that is it. And thank you for taking your time out to listen to me, and have a nice day.